Well, thank you very much, Praveen and Shane. I have the honor and privilege of introducing the first Rhee lecture. We have two Rhee lecturers today. Actually, Dr. Glassman is going to give the lecture tomorrow. We had the opportunity to give you this lecture because of the generosity of the Rhees, who provided funds in honor of Dave Bradford, our former chairman, and a mentor to many of us. So, to introduce John, John and I were both residents together at UCSF, and interesting enough, he's the one that got me into thinking about spine and to go into spine surgery. He's associate professor at Emory University with Scott Bowden and many of the powerhouses over there, and over his time there, he's been extremely productive both academically and clinically. He's published well over 40 articles on the cervical spine alone, as well as many book chapters on spine surgery and spinal disorders. He's chaired multiple courses, including the last Cervical Spine Research Society course in Los Angeles last year, and he's the chairman of the CME committee for the Cervical Spine Research Society. What you may not know about John was that he was a student at UCSF as well, and he decided to stay as resident, and he was inspirational in teaching us how to do research. He said, just come out to the lab and do some research with us. And as you can tell who the PhD was, the guy on the far left-hand side who doesn't have a tan. And everybody else was working really, really hard in our lab. And we got really productive. So without further ado, I'd like to introduce my good friend John Rhee. And he's going to talk to you about posterior cervical decompression reconstruction techniques, what works, what doesn't.
I'd like to thank Bobby and Shane and Praveen for allowing me to talk. This is a tremendous honor for me. And the departments of orthopedic surgery and neurosurgery here at UCSF have really been leaders in the field of spine surgery over the years, world-class institutions, and I'm really honored to be here. Let me see if I can get this. How's that work? So what I'm going to talk about are methods of posterior cervical decompression and reconstruction for multi-level cervical myelopathy, specifically focusing on what works, what doesn't, and what are things that we can improve. I think hopefully what you'll recognize as a recurring theme as we go through this talk is the importance of the sagittal plane when doing multi-level cervical myelopathy surgery. This has been well studied in thoracolumbar deformity. Steve Glassman is another one of the speakers that you'll get the pleasure of hearing tomorrow. And Sig Bervin, who's faculty here at UCSF, have done a tremendous amount of work on the impact of positive sagittal balance in adult spinal deformity. But I think you'll see, as you hopefully listen to these talks, that the sagittal plane is increasingly recognized as important in cervical myelopathy surgery as well. So please keep that in mind. A couple of disclosures, really only one that's germane. I do receive royalties from a laminoplasty plate, so we will be discussing laminoplasty, and please keep that in mind as you evaluate my comments. So if you're presented with a patient like this who comes in with multi-level cervical myelopathy and you decide to treat this patient posteriorly, you've got basically three surgical options. You can do a multi-level laminectomy, a laminectomy with fusion, or a laminoplasty. Now, in 2014, I wouldn't say this doesn't necessarily work anymore, but a procedure which really doesn't make a whole lot of sense to do in these patients is a multi-level laminectomy alone. And that's because while the initial neurologic outcomes might be acceptable, there's always the potential for development of post-laminectomy kyphosis and instability that can lead to recurrent myelopathy. The true incidence of this problem is really unknown in adults, but estimates range anywhere from about 11 to 47%. And even if you don't develop a recurrent myelopathy, kyphosis can certainly generate neck pain and spinal deformity. Other problems with multi-level laminectomy alone, having the dura exposed throughout the length of the decompression can create a post-laminectomy membrane that can actually cause recurrent cord compression. This is a patient from Morimoto's study that had a laminectomy, developed this sort of compressive membrane, and they went in and removed it, and you can see that the dural sac is expanded up again. But the bottom line is that a multi-level laminectomy just makes revision surgery not only more likely, but also unnecessarily more complicated than it needs to be. You've got exposed dura throughout the length of the cervical spine and a significant loss of bone stock, which can decrease local bone that's available for grafting, as well as the surface area available for fusion and reconstruction. So, clearly catastrophic problems don't happen every time you do a multi-level laminectomy. This is a patient I saw in clinic who had a remote history of multi-level laminectomy surgery, and you can see that the alignment is not ideal, but not a disaster. But these sorts of things do happen frequently enough, and given that there are plenty of other better options, multi-level laminectomy alone is generally not recommended for this problem. So what works instead, one option is a laminectomy with fusion. And the primary advantage over laminectomy alone is to avoid post-laminectomy kyphosis of the type that I just showed you. And this is a very popular operation that has enjoyed very good neurologic outcomes. If you look at the literature going back to the 80s, neurologic recovery rate ranges anywhere from 50 to 89%. And it's probably the most popular posterior option for treating multi-level myelopathy in the USA, if you look at pure numbers of surgeries that are done. But despite its popularity, there's a surprising lack of definitive literature on this problem, and therefore many unknowns. And so I'd like to go over some of those unknowns with you now. The first of these is, does laminectomy with fusion lead to a reliable improvement in spondylotic axial neck pain? Well, you would think on the one hand that fusing an arthritic segment should relieve neck pain to some extent, but you could also imagine that having a long, stiff, fused neck could be potentially detrimental to axial symptoms. This is a very fundamental question, but as I look through the literature, there's very little evidence as to whether or not laminectomy and fusion reliably improves spondylotic neck pain. Second unknown, what is the optimal bone graft for usage in laminectomy and fusion operations? Well, iliac crest bone graft clearly works, but in the year 2014, there's not too many surgeons who want to take it anymore, and none of the patients want to have it taken from them. Local bone is readily available from the laminectomy itself, but in the patient population that we serve with these procedures, elderly, osteoporotic, as you've heard, the bone can be of variable quality. Demineralized bone matrix, this is very commonly used all over the place in the literature, but surprisingly no good data as to whether it really does anything. Infuse or BMP2, we know that that works in achieving fusion, but it has an uncertain safety profile. So the problems related to infuse usage in the anterior cervical spine are widely known. About 10 years ago, we first started using infuse and ACDFs at Emory, and we noticed that there were a large number of patients that were coming back with massive swelling complications, dysphagia, et cetera. And when we studied them, we found that there was a 10-fold increased risk of swelling complications like this with the off-label use of infuse and ACDF. Now, a lot of this had to do with dosing and placement of the infuse. But due to this publication and others, in 2008, the FDA issued a warning letter on the use of infuse and ACDF surgery. And of course, the lawyers have not missed out on that. This is a website that I Googled. They're actually calling themselves the Medtronic Bone Graft Lawsuit Lawyers. I mean, this is real. You can't make this stuff up. So, but recent studies have reported complications with infuse usage in posterior cervical spinal surgery as well. like this case report demonstrating an infuse-related seroma causing postoperative spinal cord compression that had to be evacuated. And this is a patient who, in whom they used an extra small kit of infuse, so it was a fairly small dose. But the main reason why we don't know the optimal bone graft for cervical laminectomy with fusion is due to unknown number 3. What are the fusion rates associated with different graft types in cervical laminectomy and fusion? Well, this is a sampling of the literature going back about 10 years. And all of these series of laminectomy and fusion patients use local bone with or without demineralized bone matrix. And as you can see, there are a number of studies which demonstrate the rate of hardware failure and some that demonstrate fusion rates based on X-rays only. But the problem with these types of studies is that if you don't mention the fusion rates or that they rely solely on plain X-rays. And recently we did a systematic review for the CSRS on the radiologic determination of postoperative cervical fusion. And what's clear from the literature is that plain X-rays are generally helpful in assessing anterior cervical fusion because the spinous processes are available and you can readily check for motion on FlexX. The graft typically is well visualized on a lateral X-ray. But in contrast, plain X-rays may not be so helpful when assessing posterior cervical fusion. If you see a complex patient like this with a multi-level construct, it's often difficult to tell whether they're fused or not based on X-ray. Motion is difficult to assess because a lot of times these patients have spinous processes that have been removed, and the graft and the facet joints just is not well seen. So CT scans clearly are not perfect. I've seen a number of instances in which CT scans can lie and make something look like it's fused when it's not, but they are probably better than X-rays at assessing posterior cervical fusion status. Unknown number 4 with respect to laminectomy and fusion is the rate of adjacent segment disease after these long posterior cervical fusions. So adjacent segment disease is an issue that's commonly discussed in the context of ACDF. The conventional wisdom, of course, is that fusion accelerates the rate of adjacent segment degeneration, and it's been a major rationale for the development of cervical arthroplasty. But somehow this is a topic that is rarely mentioned in the setting of posterior cervical fusion. And a corollary to this unknown, what are the best levels to start and stop these long posterior cervical fusions? So the majority of patients with cervical myelopathy, the levels that are involved are C3 to C7. But when should you fuse up to C2? When should you go down to T2? Is it ever okay to just treat C3 to C7 with a laminectomy and fusion? These are all important questions with no definitive answers in the literature. But perhaps the most important unknown with respect to lami fusion is which myelopathic patients truly need a fusion. In other words, what's the indication for doing a fusion when myelopathy is primarily a neurologic problem requiring decompression? And although there are no clear answers on this, I think most of us as surgeons would agree that reasonable indications for laminectomy and fusion would be a patient who has multilevel myelopathy and either a significant instability or a spondylolisthesis or a flexible or a mild kyphosis. But does a patient like this really need a fusion? You can see they're congenitally stenotic and they clearly have multilevel myelopathy, but there's no instability. The lordosis is preserved and this patient doesn't even have axial neck pain. A lot of times myelopathic patients have no pain whatsoever. If you ask a bunch of surgeons in the US, I bet the majority would say a laminectomy and fusion for a patient like this, maybe because of the downsides that we discussed with multilevel laminectomy alone. But have we gone from one extreme to another, from not fusing to fusing everything? Or might a non-fusion posterior alternative like laminoplasty make more sense in a patient like this? So there is some limited data comparing laminectomy and fusion to laminoplasty for multilevel myelopathy. This is a paper that my partner at Emory, John Heller, published about 13 years ago. There were 26 patients. It was a matched cohort analysis, laminoplasty versus laminectomy and fusion, and they found a trend towards better clinical outcomes and significantly fewer complications in the laminoplasty group as opposed to the laminectomy and fusion group. Now, this paper would seemingly favor laminoplasty, but keep in mind Very small numbers in this study, only 13 per group. And this was a non-consecutive hand-picked series of patients that were chosen for inclusion in this study, which clearly could lead to significant bias. So you would want a randomized controlled trial, and believe it or not, there is one comparing lamifusion to laminoplasty, published in Neurosurgery several years ago. And what they found was significant improvements in neck pain, interscapular pain, and arm pain for the laminoplasty group, and only a trend toward improvement in those categories for laminectomy and fusion. Again, this would seemingly favor laminoplasty, but very, very small numbers. They had a difficult time enrolling patients in this study, only 9 in the laminoplasty group, 7 in the lamifusion group, so again, no definitive answers. But regardless of where you stand on the whole issue of whether lamifusion is better than laminoplasty, I think what's inescapable from the literature is that laminoplasty does work in the properly selected patient. Now, the ideal indications for laminoplasty would be the patient with multilevel myelopathy who has preserved lordosis and minimal to no axial spondylotic pain. It's important to keep in mind that laminoplasty is not the ideal operation for kyphotic patients because, as you know, compression in the cervical spine often arises anteriorly. It doesn't always, but typically does so. And laminoplasty relies on cord drift back for decompression, which, if you have lordosis, the cord can drift away from the anterior structures, but it's not going to occur in the setting of significant kyphosis. Now, one caveat to that explanation is that even in kyphotic necks, you can get some measure of a decompressive effect from the dorsal structures by releasing the ligament flavum and the lamina. You'll get a dorsal effect of decompression, but in the setting of kyphosis, there will be persistent anterior compression. But assuming you have the right patient, laminoplasty, I think, in the literature has clearly been demonstrated to allow for an excellent, quick, multi-level decompression of the spinal cord, less likelihood of developing significant kyphosis of the type we talked about with multi-level laminectomy, neurologic outcomes going back to the 1990s that are similar to those achieved with anterior surgery, and no need for fusion, either anteriorly or posteriorly, and all of its attendant complications like adjacent segment disease, hardware failure, etc. But I think as spine surgeons, we probably know better than almost anybody that there's no perfect operation, and laminoplasty is not an exception. It can be a great operation that unfortunately does carry some baggage. So the pro side are all the things that we discussed: quick decompression, no fusion, excellent neurologic outcomes, low complication rates, but there are a number of downsides as well. So let's talk about a couple of those. The first that's often associated with laminoplasty is this whole issue of axial neck pain. And to be clear, laminoplasty should never be intended as a treatment for spondylotic axial neck pain. But the controversy centers on whether or not the axial pain associated with laminoplasty is new, postoperative in onset, or whether it's just merely a persistence of spondylotic pain that's been there all along. And if you look through the literature, there are a number of studies that debate this back and forth. The bottom line is that it's conflicting and unclear and unresolved. For what it's worth, in my own anecdotal experience, after doing a lot of these procedures, I've found the following. If you have a patient without major axial pain pre-op, they rarely, if ever, develop axial pain post-op after laminoplasty, assuming that they have not developed kyphosis or an instability. On the other hand, patients who come into you with a major component of non-neurogenic axial pain pre-op, they will often complain of worsening of axial pain postoperatively after laminoplasty. So again, this underscores that proper patient selection is critical to laminoplasty success. What about loss of lordosis? That's another issue that's associated with laminoplasty. Clearly, laminoplasty was conceived in order to avoid this type of catastrophic kyphosis that you see with laminectomy and multi-level laminectomy alone. But emerging literature shows that some loss of lordosis does occur even after laminoplasty. And that can have consequences in terms of neurologic deterioration, deformity, and axial pain. This study by Dr. Suk in 2007 demonstrated on average about a 5-degree loss of lordosis after open-door laminoplasty, and 11% of the patients in this series actually developed a frank kyphosis. A few years ago, we reviewed our own series at Emory looking at loss of lordosis following cervical laminoplasty, and we had a similar result. At 1 year, the overall loss of lordosis was about 6 degrees, consistent with what's been seen in the literature. We dug a little deeper and identified a variable that we termed the forward pitch, and this was defined as the perpendicular distance from the C2 plumb line to the lowest instrumented laminoplasty level. It's basically the sagittal vertical axis. We define this as positive if that plumb line was anterior to the LIV, and negative if that axis was posterior to the LIV. And what we found is that in those patients who had a lower forward pitch, so what that means is that their head is better centered over their neck, they tended to lose about 3 degrees less lordosis than the people who had a head that was sort of pitched forward and not well centered over the neck. And this difference in loss of lordosis occurred even though the amount of preoperative lordosis was no different between the two groups. So in other words, the two groups both started out with about 10 degrees of lordosis, but those who had a greater forward pitch tended to lose more of that lordosis postoperative. I think based on that, it's prudent to at least consider alternative operations to laminoplasty in patients with a high forward pitch like this one, even if their overall lordosis is still present, because they are at risk for increased postoperative loss of that lordosis. We did a follow-up study of these same patients looking at the clinical outcomes, and what we found was, again, that those patients who had better balance, basically a head centered over their neck, had significantly better clinical outcomes as well in terms of MJOA improvement, myelopathy recovery rate, and even the SF-36 physical functioning subcategory. And this is consistent with published work correlating cervical sagittal balance to outcomes, a lot of which has been done here at UCSF. Vedat Deviran and Chris Ames published this study on the impact of standing regional cervical sagittal alignment on outcomes in posterior cervical fusion surgery. Another issue with laminoplasty is that some loss of range of motion does occur. It's not a fusion operation, but the literature is consistent in that patients lose about 30% of their total arc of motion after a laminoplasty. This study by Hyun looked at the time course of that loss of range of motion. 23 patients underwent open-door laminoplasty with plate fixation. There was about a 10-degree loss of range of motion, again, about a 30% loss. And what they found was that that decline is gradual rather than sharp. You can see the red line there that kind of averages all those different patients, and the plateau was at about 18 months. Thankfully, this does not seem clinically limiting to laminoplasty patients. This is another paper that came out of UCSF, Dean Chow and Praveen Mumanidi. They did a similar study looking at range of motion after plated laminoplasty and found that it decreased about 8 to 14 degrees, depending on the diagnosis of whether it was spondylotic myelopathy or OPLL. But again, there was no correlation between a decrease in range of motion and neck pain. So thankfully, this is something that we see radiographically, but may not have as much of a clinical effect. And one of the other issues with laminoplasty is the potential for loss of fixation. So traditionally, sutures were used to prop laminoplasties open, but over time, these sutures can either break or loosen, causing loss of fixation and recurrent cord compression. Matsumoto's series in 2008 demonstrated about a third of these laminoplasties open with sutures, prematurely closed. And then the other classic technique is to use bone, like a rib strut graft like this. But the problem with that, if you've ever done it, is that if you make that hinge side too floppy, then the graft is not very stable, and it can either kick into the canal or out of the canal. Either way, not good in terms of keeping the canal open. In Japan, they use these sorts of hydroxyapatite spacers to keep laminoplasties open. And this series reported about 3% where the spacer migrated anteriorly into the dural sac and caused neurologic deficits. So can these issues with laminoplasty be improved upon? Well, increasingly recognized when doing laminoplasty is the importance of preserving the posterior extensor mechanism. For example, the C2 muscle attachments. The cervical extensors insert onto the C2 spinous process and act as a tension band to help maintain lordosis. And the literature shows that preservation of these insertions appears beneficial in terms of axial pain, less axial pain if you do that, better preservation of lordosis, and less loss of range of motion. So the traditional laminoplasty exposure, you would do a very wide dissection from C2 all the way down, detach all those insertions, and then at the end of the case, you would try to reinsert them. And if you've ever done that before, you know that that is fiddly to do at best and unreliable at worst. So a more modern approach now is to do a selective laminoplasty exposure and trying to preserve those C2 muscle attachments as much as possible from the get-go. So again, with a traditional laminoplasty, you would do a C2 dome laminectomy, C3 to C7 laminoplasty to try to maximize the amount of spinal cord drift back. But with a more selective approach, you can do a laminoplasty only of the stenotic levels, for example, C4, 5, and 6 in this example. And if you need a little extra drift back, you can do partial laminectomies above and below that. The idea being that less muscle dissection may lead to better extensor muscle function. And this was shown in a retrospective cohort study comparing selective versus standard laminoplasty by Tsuji in Japan in terms of JOA recovery rate, overall lordosis, and decrease in range of motion. They didn't find any difference between the two groups, but in terms of axial pain scores and the rate of C5 palsy, this significantly favored the selective laminoplasty. And the thought was that perhaps there may be less C5 palsies because there's less cord drift back and therefore less stretch on the C5 root. So to evaluate the effect of less muscle dissection on postoperative loss of lordosis, we've done a study where whenever neurologically possible, we try to make C4 rather than C3 the proximal laminoplasty level. And the rationale is that when C4 is the proximal laminoplasty level, you do have to detach a little bit of the muscles onto the bottom portion of C3. You often need to unshingle C3 on C4 by laminectomizing the bottom part and uncovering the C3-4 disc level, but you can leave the C2 muscle insertions completely intact. On the other hand, when C3 is the proximal laminoplasty level, some amount of detachment of the C2 muscle insertions is unavoidable because without doing that, you can't really uncover C2 off of C3 to be able to open up the laminoplasty. Now, C4 can be the proximal level if there's no stenosis at the C2-3 segment, which is the case in most patients with cervical myelopathy. Most patients do not have stenosis at C2-3. Obviously, you want to look at that on an MRI. But in such patients, if you do a C3 dome laminectomy along with a C4 laminoplasty, you can get satisfactory decompression of the C3-4 disc level. And you can see that here on the MRI on the right-hand side. And what we found in our study is that if you started the laminoplasty at C4 rather than C3, there was significantly less loss of lordosis, about 5.5 degrees less. Another area for potential improvement could be through the use of plate-only laminoplasty constructs. Plate-only laminoplasties are done just in the traditional open-door type approach, but instead of using sutures or bone, a plate is applied, and you really don't need to do any supplemental bone grafting. You can see from this CT scan that if you apply a plate, the hinge can heal on the hinge side, and you recreate expanded laminar arch without the need for supplemental bone. And we looked this up several years ago, 53 patients who had plate-only open-door laminoplasty, no supplemental bone grafting on either the hinge or the open side, and we did a CT scan analysis and found using relatively stringent criteria that about 93% of the patients, or the levels actually out of 217, had healed completely with bone by 12 months post-op. So there were no premature closures, no plate dislodgements, and no plate fractures. Now, this is not complication-free. You occasionally will see screw back out. We saw it in about 2%. But even in those cases, all of the laminoplasties remain patent. Either the hinge would heal anyway, even though the screw had backed out, or you would develop potentially a stable fibrous union like this because keep in mind that all of the lamina are connected to each other, sort of like in a suspension bridge type fashion. And so there's not a whole lot of stress placed on these segments individually. We concluded that plate-only laminoplasty maintains stable spinal canal expansion with high rates of hinge union, no premature closures, and no plate failures, and that supplemental bone grafting is not necessary when performing a plated laminoplasty. So one thing that's come up in the literature is that although plates are relatively forgiving, meticulous technique is important. You want to try to create as springy of a hinge as possible, not broken, and make sure that you have stable plate fixation, because this study by Park demonstrated that hinge fractures may be associated with increased postoperative axial neck pain. In this study, what they found was that the presence of 3 or more hinge fractures was significantly associated with worsening of VAS neck pain and NDI scores. So in conclusion, when performing posterior surgery for multi-level cervical myelopathy, I think it's pretty clear multi-level laminectomy approach alone is really not ideal to do anymore in 2014. Laminectomy infusion works well, but there are a number of questions that remain with respect to the optimal bone graft, the optimal number of levels to fuse, what's the rate of adjacent segment disease over time, and perhaps most importantly, which one of these patients who comes in with primarily a neurologic disorder, many of these patients don't even have any pain, how many of these patients really need a fusion? And in what subset of those patients would a fusion be beneficial versus not necessary? As we discussed, laminoplasty works very well in the properly selected patient, but it's clearly not perfect, and there's room for improvement. Techniques in terms of muscle preservation, preserving the C2 muscle attachments, avoiding a C3 laminoplasty and starting at C4, doing selective laminoplasty and plate-only constructs have been beneficial in that regard. So the overriding theme that really should be considered when doing posterior surgery for multi-level cervical myelopathy is to design an operation that not only fully decompresses the cord, but also adequately maintains or restores sagittal alignment. So in the time that I have, I'm going to go over a quick several illustrative cases that hopefully will drive some of these points home to you. And then we'll get you off to lunch, because I know I'm the only thing standing between you and a meal right now. This case is a patient who comes in with multi-level myelopathy. If you look at the x-ray, the overall C2 to C7 Cobb angle is slightly kyphotic, about 2 degrees of kyphosis. She has absolutely no pain. It's purely a neurologic problem with classic myelopathic symptoms. You can see on the MRI there that she has multi-level cord compression from the C3-4 disc space down with some signal change at the C4-5 level. And in a case like this, I think it's more than appropriate to do a laminoplasty. I don't think a patient like this needs a fusion. We did do a C4 rather than a C3 laminoplasty. We did a laminectomy of C3. We totally preserved the C2 muscle attachments, and the patient did not lose any lordosis postoperative. Here's a, on the surface, somewhat similar case. Again, if you look at the overall alignment, there's a mild amount of kyphosis. But looking a bit more carefully, you can see circled there, there is an area at C3-4 of non-correctable focal kyphosis. And of course, that coincides with this large calcified disc herniation occupying over 50% of the spinal canal. And then below that, he has multi-level cord compression as well from C4 to C7. So given that large mass within the canal, posterior decompression alone would really not be adequate to achieve a decompressive effect. This patient needs an anterior operation, but because there's so many levels involved, we decided to back it up posteriorly as well. So he had an anterior C4 corpectomy and then a multi-level posterior fusion. Here's another case. This patient has a very rare disorder called Gorham's disappearing bone disease. There are probably about 10 of these cases reported in the literature, extremely rare. Nobody knows why it happens, but in some people, their bone just vanishes. It just disappears. So if you look at this patient where the arrows are, notice that C1 has been partially eroded away. It looks very wispy. C2, the lamina, the facets, the pedicles completely gone. Spinous process completely gone. C3, same sort of thing. C4, not quite as bad, but there's significant amounts of bone loss leading to a kyphotic instability and therefore a profound myelopathy just on the basis of kyphosis. So the goal here is to correct the kyphosis. The best way to do this, we thought, was to go posteriorly initially and do a posterior realignment, occiput to T2 fusion with rib strut grafts to span that large defect that she has. And then because we wanted to make sure that this healed, you really have to think of this problem almost like cancer. There's a possibility of recurrence, and we wanted to make sure that everything healed, so we went in anteriorly as well and fused everything from the front. And she went on to heal everything and has done quite well. And then finally, this is a case of a patient who has had multiple prior cervical spine surgeries, also has had some lumbar surgery as well, comes in with a chin-on-chest deformity. And unfortunately, she's had multiple procedures where they put in plates and screws, take out plates and screws. I think there was an infection at some point. The bottom line is that she unfortunately went on to heal in this kyphotic position and has myelopathy as a result of the kyphosis. And this is another paper by a UCSF author, my good friend Bobby Tay, on complex deformities of the cervical spine. Would encourage you to read that. But basically, this was a fixed deformity that required a 3-column osteotomy. We went posteriorly. You can see this is the x-ray on the table. There's not much correctability to this. It was rigidly fused. I wasn't quite sure on the CT scan, but once we got in intraoperatively, it was obvious that it was solidly fused. We established fixation points and did Smith-Peterson osteotomies and went in anteriorly, osteotomized the anterior fusion mass, and then went back posteriorly to reduce the osteotomy and close the construct down. So the goal, again, being restoration of sagittal alignment and therefore improvement in myelopathy. Thank you so much for your attention.
One or two questions for our guest speaker, and then after that, everybody's welcome to go to lunch. Also, faculty, if you meet me up here, we have a faculty lunch as well.
Yes, sir.
I enjoyed your talk very much. One point that I would like to make, having been in this business a long time now, is that I truly believe that if you preserve the lateral masses, you're not going to get the post-operative problems with sagittal balance. I think that happens only when you go out too wide into the lateral masses, unless it's an unusual case. But in an average standard myelopathic case, I don't believe you need a fusion or a laminoplasty. I think that the garden variety type case, if you preserve those lateral masses and decompress the dorsal dura, if you're doing it for purely myelopathy, not radiculopathy, you're not going to need any of this stuff. And that does fulfill that criteria of preserving sagittal balance.
Yeah, thanks for your comment. As I mentioned, you're not going to get catastrophic failure every time you do a multi-level laminectomy. I think there are a number of factors involved. Certainly facetectomy clearly has something to do with it. And often what I see in patients who have had a laminectomy and facetectomy is not only do you get the kyphosis, but you also get spondylolisthesis, which makes things worse. But I think there are a number of factors involved. One of them is the preoperative alignment of the spine. So if the patient starts out somewhat kyphotic and you do a multi-level laminectomy that does not preserve the C2 insertions, even if you do a laminoplasty that does not preserve the C2 insertions, you're going to likely get a significant loss of lordosis. Now, whether that becomes a catastrophic problem or not, it's hard to say, but I appreciate your point. I just think that there are alternatives, and a laminoplasty is, I think, easier than a laminectomy and it can significantly decrease the rate of catastrophic kyphosis. It doesn't completely eliminate kyphosis, as you've seen, but it can decrease the rate of that, so that's my own personal preference. Yes, sir?
Hello, Max Matos, Costa Mesa. I'm an orthopedic surgeon, and I would like to make a comment about controlling cost. I think every time a decision is made to control the cost of medical treatment, you take the treatment from the doctor and give it to the insurance company or administrator. It automatically creates many layers of administration, and it results in a tremendous cost for the surgeon to perform the appropriate treatment. And you know, it is becoming out of hand and in a perverse manner. I have seen many times where I request, for example, a simple, cheap item, and the rebuttal and the denial cost them like 10 times the cost of the item I was trying to prescribe. That's my observation.
Yeah, I think that's a great point. A little bit off the topic of what we were talking about, but you know, it's interesting where cost adds up. And I am no expert on this, but my understanding is that outpatient care swamps inpatient care in terms of total cost. So it's interesting how they decide what to cut and what not to cut. Dr. Glassman?
You didn't really talk about Michael Fahling's study for cervical myelopathy, where they didn't randomize the two treatments, but they had about equal numbers of laminoplasty versus laminectomy infusion. And getting to the cost issue, I think that what he reported, you correct me if I'm wrong, is that in Europe people generally did laminoplasty, and in the US people generally did laminectomy infusion, and the implication was sort of it's because of what's reimbursed, here that drives that. I don't know what you think about that.
Yeah, that's a great point. I think you're referring to the AO spine myelopathy study, and that was a non-randomized trial. It was the surgeons would decide what type of treatment they offered to the patients with myelopathy, and then the patients were prospectively followed. And I think the upshot of that paper is that any one of the treatment options can work, but obviously you have to consider things like alignment, whether the patient needs a fusion or not, and then your own comfort level with various different operations. But I think there are a number of different ways to skin a cat, and a variety of options can work, but I think you do need to keep in mind, if not this time around, for what's going to happen in the future, try to preserve sagittal alignment or restore it to the best that you reasonably can. I don't think you should turn every one of these cases who has a little bit of sagittal imbalance in the cervical spine into a front-back C2 to T2. I think that would be overkill. So I think one of the areas that's ripe for research is to figure out, who needs a fusion. If you're going to do a fusion, which levels need to be done, what degree of kyphosis actually needs to be corrected, versus, can you get away with sort of a passive correction and locking down the instrumentation? Those are all very, very important questions that we need to answer. Thank you for your comment. Yes, sir.
I just had a specific question about OPLL, or ossification of the posterior longitudinal ligament, which is known to progress over time, as was demonstrated. It was a Japanese unoperated series a long time ago in both the AP or axial and longitudinal directions. And the literature seems to be confusing as to whether it makes any difference to fuse those patients to prevent progression. There's some studies with laminoplasty that suggest that may also inhibit anatomical progression.
Yeah, I think I completely agree with everything you said. My own algorithm for OPLL is that when it's relatively mild, and let's say the amount of canal compromise is 30% or so, and the patient has reasonable lordosis, often those people are pretty stiff to start out with. And so they're not at high risk for losing lordosis post-op, and you can get a reasonable posterior decompression. In those kind of cases, I'll do a laminoplasty for those people, but for people with large focal lesions, like a beak-type lesion that's acutely impinging the cord, if there's more than 50% canal compromise, those people, I generally do a laminectomy and fusion, thinking that maybe a little more drift back might be helpful, and it would also be helpful to have a solid fusion in case my posterior approach doesn't work well enough. I can go in anteriorly and do a very radical corpectomy and not have to worry about stability and healing.
Okay, great. Thanks very much, John. We do have box lunches outside, and faculty, if you could meet me up at the front.